Kia ora tātou. Thank you for the daunting privilege of speaking with you. I'd like to start with a quote from Dr Jonathan Gray that knowledge resides in the network, not in the individual. Amen. But I would also like to acknowledge my colleagues from palliative care here today that provide that network. The individual, however, is also very important, and I want to thank Atul Gawande and the Health Quality Safety Commission for making this day happen. For palliative care, this is actually a very, very important day that we are here in this mix of people having this discussion. Since 1990, any talk about palliative care has started with the WHO definition. It's traditional. It was revised in 2002 to include life-threatening rather than terminal, and to include early identification of symptoms. It became much broader. It also has a definition for paediatric palliative care. I'm sorry that Ross Drake, who's the face of paediatric palliative care in New Zealand, can't be here today. They deserve their own airtime and can struggle to get it. When I look at that definition, I find palliative care is very hard to separate from good old medicine, good patient-centred, multidisciplinary medicine, care. Any discipline could be doing this, any discipline should be doing this. Palliative care is not defined by an organ or an age or an intervention or a disease. Neither are we purely generalists. There are some things that we don't do. Reflecting on my work, I come up with, it's not a definition, it's a bit of a description about what makes me and my work. Having said this does not apply just to a doctor, this applies to any of my clinical team. And having said that, it applies to my specialist palliative care team, it applies to everybody in healthcare. By having no agenda, it means that I'm not just limited to hearing medical issues or even end-of-life issues. It means that I'm not infatuated with medicine, that not even infatuated with myself as a doctor. I'm aware that palliative care strove really hard to get recognised as a specialty in 2000. And I am sort of in love with medicine. I saw the view from a camera inside somebody's coronary artery. I mean, how much fun is that? But it's a central theme in what we're discussing today, that medicine has its limits and we need to recognise that. So this is a cartoon from a Lunig's, a Melbourne cartoonist, and for me it's wanting to explain how palliative care is married to medicine and where I think we should be heading, perhaps in the relationship between community and medicine. We're gathered to witness the marriage. I hope you can read that, because I can't say a complete and an absolute in public. But actually that's the sense of the marriage that palliative care there is no question that we have to remain married, but not subsumed and perhaps a little disruptive. I don't want my hospice to become a mini hospital. It has different work to do. And there is some pressure, not least from patients, to start doing more sophisticated interventions which we don't have particular expertise in. And it feels like selling people a fake Rolex watch. You may argue that at the end of the life, that is exactly when you need a fake Rolex watch, but that is actually an important debate. And my opening bit is that we don't do plural taps. You go to the hospital. I want to define what we do. Does that make this a simple job? We have the discussion, we cope with the results, we talk, we prescribe, we refer. We keep our eye on the big picture. There's more to life to medicine. So maybe it's simple, but maybe it isn't. But it is the scope and the size of the work that really makes the eyes water. So when we look forward, as we've started to do, we need everybody involved to have these skills in communication, and we know and the knowledge where to find the resources to cope with the issues that arise, to help meet these goals, whether they are comfort, whether they are family, whether they are spiritual. And so we also need to be able to develop those resources. So, palliative care is ubiquitous. It's everybody's business. Includes the hospitals, single most common place to die, 34%. Includes the aged residential care. If you're a woman, that is the single most likely place that you will die. And dying in the community at home, 80% people want to die at home, perhaps 25% do that. That is the big three. I can hear Ross Drake, who heads paediatric palliative care, saying adult palliative care gets 150 times more funding than paediatric palliative care. And he's right, and we just need to keep that in the back of my mind. The challenge is how to get palliative care on the map in these places. They're filled with busy people with unique expertises, doing good work in their own sphere. Palliative care has to blend in. Palliative care is only ever a subset of their work, even in aged residential care. And maybe we can't do that without the dedicated palliative care teams flying the flag in each of these scenarios. But is it it's an influence, it's a modelling, it's a teaching presence rather than a doing. Doing everything is obviously impossible. Enabling may be a better word. Giving permission to do stuff. People in aged residential care do not want to send their residents to hospitals. They do want to give them bananas, cookies, and booze. It's a matter of enabling them to do actually what they really want to do, and which some people are saying, actually, you shouldn't do that. There also needs to be this focus on palliative care expertise in service development. Workforce issues are a very big issue, and not just for palliative care. The training and education. Research and symptom management is surprisingly difficult to do, but we also need research into the economics of service delivery, of service models, of community needs. Let me just touch on these three things. This palliative care in hospitals. Some of this in hospitals is providing the ubiquitous palliative care, and some of it is providing the focus of specific teams, comprehensive teams, doctors, nurses, nurse practitioners, administration psychologists, but also within the hospital developing the expertise of speech and language therapy, dietetics, pharmacy, OT and physio, who may not be on the team but actually need specific expertise in palliative care. I perhaps explain the models of care and rather than or. So in Wellington, the palliative care team will see all of the patients before their autologous stem cell transplant in haematology, rather than do the stem cell plant and then, if it all goes to custard, see palliative care. Or going to a multidisciplinary team meeting, and yes, surgery is a good idea, and palliative care is actually a good idea at the same time. There is this dilemma, obviously, in terms of resource, in terms of balancing what the resource is and what is a great thing to be doing. Just acknowledge the integration of palliative care into the cancer tumour streams, which is a new thing, and it is good and it is happening. In aged residential care, there is a lot of palliative care being delivered very well, and when it is done well, it is due to the passion of the staff. That is what I hear. The fact that they are becoming de facto hospices is not in dispute. The great majority of people over 85 will die there, but also young people are dying in aged residential care for the sake of a better place to die. And palliative care is resource intensive, not always, but certainly at times, and that needs to be recognised in age residential care. Talking about the systems, checklist systems, the Liverpool Care Pathway, I think, was a very good example of a system introduced which became the norm. And for reasons it has been withdrawn, and we are now re-looking at guidelines for care at the end of life. And hopefully that will go well. I hope that Air New Zealand has sent their Boeing equivalent to check them out. It just seemed like a good idea at the time. Hospices have traditionally been involved in the community. The community has its champions in general practice, but still the largest burden in palliative care is actually being happening in primary care. As a specialist palliative care physician in my team, I would see 40% face-to-face of the patients on my books. Just 40%. If I was in Australia, I'd see them all because I'd need the billing. But here, it's quite different. The community itself perhaps has the key to those demographics that are hitting us. I think Barry Snow will talk about the advanced care planning. We want in our community perhaps hospice is rediscovering our mojo that we had in the 60s and 70s in terms of public health and getting the messages out there. The community level discussion, compassionate communities, death cafes, public lectures. But also we want to train and educate volunteers and community members to look after their own. If it takes a village to raise a child, when that child has to care for a dying parent 40 years on, I think the village has to be for them there again. And lastly, there is this macro level, the systems level, the health system. Palliative competency and literacy refers to the ubiquitous necessity of palliative care. Training is a huge vexed problem. Clinical networks are happening, regional networks, but often being done by people who have day jobs. They rely on goodwill. They have to rely on goodwill. I mean, that's part of the cooperation that we've been hearing about today. Paediatric palliative care has actually taken a bit of a lead in having national networks put up. But I do think there's an agreement for national leadership for palliative care in all its forms within the ministry. And we look forward to the development of further end-of-life palliative care strategies within the ministry by people who have a dedicated responsibility for palliative care, who recognise it needs to be ubiquitous throughout the system and it needs to be focused on helping developing expert times. I feel my time is coming to an end, and quite appropriately I'll listen to that feeling. Thank you.
Thank you very much, and I also feel privileged to be here, and it's great to share a platform with Atul Gawande's book, and I think his book is going to do a great deal for spreading the word of what we do in geriatric medicine. So the first few slides came out of a talk I used to give on resuscitation in the elderly. And they were some fictional cases that I presented as a way of discussion. And then I'd like to talk briefly about communication, something about ethics, AIDS residential care, which we've touched on, a word about dementia, and then what I think we should be doing in New Zealand. So this is a completely theoretical case, but this is a 54-year-old male with progressive dementia, which can occur in people of that age, whose mental test score, very simple test, is 1 out of 10. He lives with his wife. He needs supervision with his activities of daily living, and he appears to be quite happy despite his dementia. And he comes in with an acute MI and then has a cardiac arrest. And the question I used to ask the audience was, what do you think we should do? Should this person be resuscitated? And just as in a test of ageism, I then asked the same case, but an 86-year-old, to see what the response would be. Otherwise identical. And this is another theoretical situation, but sometimes faced by some clinicians. A 94-year-old woman with previous strokes who's bedbound and incontinent, who's come in with drowsiness and she's got extensive pneumonia, who lives with a daughter who's a healthcare worker. And the question is, should we resuscitate her if her daughter wants her to be resuscitated if she has a cardiac arrest? So here's the way I addressed this before. Was I had little cards which my two daughters made for me a number of years ago. And the cards have got a green and orange side, and I got people to hold them up in their hands to say yes or no according to what the card shows. The reason for that is people sometimes look around the room and see what everybody else is voting when they hold up their hands. And so I got my colleagues. It's quite impossible to do that in this audience because you're a very large audience, but I got my colleagues at Middlemore to do it, and there they are holding up the cards. I might just say as an aside, in our department at Middlemore Hospital in aged care, geriatric medicine, we're very fortunate because we have some of the physicians who work in the acute end of the hospital, some work in acute stroke care, some work in acute general medicine, and some work in the community, and several of us work across all those boundaries, which I think is very useful. So one of the key messages I have about geriatric medicine is geriatric medicine is not knowing what to do, it's knowing whether to do it. And this is a quote from a paper some years ago about CPR, which is just perhaps an example of many interventions that we may consider for our patients, particularly our older patients. The important thing is that age alone is not a factor when determining outcome from CPR, and if you have those conditions on the left of that slide, then your outcome from CPR is very unlikely to be successful. Yet if you've got a witnessed arrest and it's due to ischemic heart disease and it's a ventricular fibrillation and you have early access to treatment, then maybe you have quite a good survival. Just moving on to a word about communication. When I was a medical student, I was told that a stethoscope, I thought that the most important tool for a doctor was a stethoscope. And in fact, I can remember proudly being given my first stethoscope. And when I was a geriatric medicine trainee, I was taught that the telephone is the most important tool because you need to phone your patient's family to get collateral history. This is what I think is the most important thing I do, and the most important tool in the type of medical practice that I practice, which is a family meeting. And this is a family meeting from about 2 weeks ago with one of my patients. So she's consented and her family's consented to the photograph being shown. There she is with our charge nurse, our speech language therapist, OT physiotherapist, and her two daughters. And in fact, you probably can't quite see, but on the table there is a telephone or teleconference unit, and her two sons are also attending, and they are both medical practitioners. And you can see I'm still clinging to my stethoscope, which is where I was seated there a moment before I took the photograph. I've still got the stethoscope, but this, I believe, is the most important thing I do. So just a word about communication. Has been a theme through this conference, but there's research that shows elderly people welcome discussions. I'm sure everybody does. And we've touched on the fact that we should be talking about the goals of therapy rather than the procedures. What procedures would you like is not really what the patients or the families wish to hear. They want to know about the goals. I don't believe we should ever say to people, there's nothing I can do. I have heard that from doctors I've worked through in my years of training over the years. But we should never say there's nothing that I can do. And we should always provide alternatives. If there is always an alternative that we can offer. And listen, which I think has been touched on. Many patients will give clues to you that they wish to have a further discussion about these issues. And most patients who are older feel comfortable discussing resuscitation decisions or other decisions with their doctors. There might be some evidence that younger patients find this more distressing. But doctors feel uncomfortable about discussing these issues. 30% of them do, but only a small minority feel uncomfortable discussing with the relatives. So what doctors sometimes do is they discuss the procedures or the plans with the relatives rather than with the patient, because they feel more comfortable doing so. There's interesting research which shows that if you give people information about resuscitation, as an example of an intervention, that the wish to receive that intervention declines after discussion when they've got the information they require. And many patients who actually said they wish to be resuscitated, actually if you ask them specifically what they don't want prolonged life support. They might say they want resuscitation, but in fact when you ask them in detail what they don't want prolonged life support. And if you test patients about how much they know about the procedure, the ones who choose to do not be resuscitated are better informed. Just a word on ethics. The 4 pillars of ethics are autonomy, justice, beneficence, and non-maleficence. I think there was an interesting thought at an ethics conference I went to recently about a degree of benign paternalism where perhaps doctors can give guidance to patients about making decisions, and that, I guess, challenges the thought of autonomy that we believe is very important for our patients. But I certainly, as a doctor, sometimes get asked by my patients, and I'm sure you've all had this experience, the health practitioners in the room, what would you do in my shoes, doctor? And non-maleficence, or first do no harm, is very important when you're dealing with old, frail people. Futility is difficult. We often say it's futile to do this because the definition of futility is not firm and changes from person to person. And truthfulness and honesty is a very important ethical concept. So qualitative research has shown that, or has suggested that patients' therapy preferences are guided by outcomes, not the treatments themselves. And people do consider advanced age as something relevant to their decision making. Sometimes older people wish to assign authority to others when they're making a decision, and that's also the importance of the family meeting, and they want to be cared for. Very human thoughts. We've touched on this before, but 38% of people in New Zealand die in aged residential care, and that asks the question of primary care providers in aged residential care: do they have palliative care training, and do they have geriatric medicine training? I know a number of them do, but the question is there. I'm grateful to Joe Broad and Michael Boyd from the University of Auckland who've given me the next 2 slides. But yes, Atul is correct that many people in New Zealand die in aged residential care. 38% you can see there. Here's a comparison. 34% of people in New Zealand die in acute care hospitals. And of that 34%, 10% are actually patients who've been admitted from aged residential care to the acute hospital. This is an interesting, a nice concept or pictorial idea of how aggressive care, giving way to palliative care towards the end of life in the conventional model, can perhaps be changed to something more like this, where there is overlap, and the idea that the palliative care team is involved early on in the patient's care, I think is exemplified by this slide. So a word on dementia. One thing is to say is that dementia varies in severity, and some patients have got mild dementia and they can participate fully in the discussion. They can understand as well as anybody else and can make autonomous decisions. When patients' capacity to make decisions is impaired, then pre-existing wishes or pre-expressed wishes is very important for us to ask families what those wishes were, and it's very important for us all to articulate those wishes to our loved ones. There is a legal framework for enduring powers of attorney. There are some treatments which are useless in advanced dementia. And what comes to mind, for example, is in advanced dementia, artificial feeding via nasogastric tube, which was practiced in the past in some areas of the world, has been shown in some controlled studies subsequently to be quite useful and burdensome and increase suffering of our patients. But we mustn't make value judgments when we make decisions on aged care. So just to finish up, see I've got 2.5 minutes left. What should we be doing? Well, I believe that the family meeting is a powerful tool for planning care. Physicians can provide prognostic information, talk about the goals of care, perhaps give some judicious recommendations to use or withhold curative treatments, perhaps consider not to harm their patients, and then patients and families can define agreed goals. What else should we be doing? Well, I think we should be improving palliative care training in aged residential care. We need to improve the links between palliative care and geriatric medicine, continue to encourage advanced directives. One last comment I'll make is maybe the acute care hospitals may not be the best place for some elderly patients. It seems that sometimes the easiest route for the older, frail person is to come to the acute care hospital. That's the default if the person's getting sick in aged residential care, and it's perhaps on a weekend or after hours. Get an ambulance and send them to hospital, to a busy emergency department, is often the course of action that is taken because it's the pathway of least resistance. But it may not be the best place for some elderly patients. So thank you.
Well, thank you for the invitation to speak. Amongst those jobs, I'm the medical lead for advanced care planning in New Zealand, particularly representing the ACP cooperative. Can I have a show of hands who belongs to cooperative? Yeah, a lot of people in this room, so you already know about my talk. Atul just sat down and I accused him of giving the rest of my talk, and he said, pivot, so I better pivot, I think. I've been a doctor for 35 years now, and I came from the same Rotorua hospital that Ian Civil and Mary did, the crucible for quality care in New Zealand. And 35 years ago, when I was a first-year doctor, I did a ward round with a surgeon who's a very good surgeon, and we'd admitted a patient with an acute abdomen. We took him to theatre and opened him up, because there's no scanning in those days, of course, and he was full of cancer, just absolutely full of cancer. And so the surgeon had no choice but to sew up the abdomen and put our patient in recovery. And I still remember vividly the kind, careful and complete conversation he had with the patient's wife. It was very humane. And our patient recovered over the next couple of days, and we were approaching his room on the ward round, and I was wondering what's going to happen now, because the house surgeon just watches, of course. And his wife came in from an angle and intercepted us and said, "Don't tell him, he'll only be upset." So we didn't. And even as a house surgeon, I knew he knew. And I knew we knew he knew. And it was kind of one of these Russian doll situations about how many times around the cycle it did. But we didn't tell him, and you sent him home, no doubt to die, and I don't know if he was ever really told. And that at the time was not totally unacceptable behaviour. I think that you'd agree it's unacceptable now. But it was, at the time, it was acceptable. Acceptable for sort of three broad reasons. Firstly is that we were then and still are a death-denying culture. It's just not polite to talk about it. It certainly wasn't then. The second thing is, I'm going to show you some more data in a moment, is that patients actually wait for the clinician to raise the topic, and we didn't. And the third thing is that at the time it was quite permissible not to tell the patient the whole facts. In fact, not telling the patient the whole facts is deeply embedded in our medical DNA. Now here's a famous Harvardian, Oliver Wendell Holmes. This is the senior. The junior is the one who became the great justice. And he was a great doctor by all accounts, a great communicator, interestingly, and the dean of the medical school. But in the graduating class in 1891, he was able to say that the patient has no more right to the information you have about the illness than he has to the medicine you carry in your saddlebags. Those are the good old days, isn't it? Your children, your wife, your patients, as you're told. But anyway, but this wasn't an isolated view of the world. The first code of the ethics of the American Medical Association was able to say this: the obedience of the patient to the prescriptions of his physician should be prompt and implicit. He should never permit his own crude opinions as to their fitness to influence his attention to them. And this survived into the early part of the 1900s. And it wasn't until the 1990s or so that we were getting absolutely explicit statements to the opposite, that this is just no longer acceptable. So it's in our DNA. Now, why is it important to turn this around? We were seeing our patient at the very end of that curve. Almost certainly he'd been having chronic illness type symptoms for quite some time, but in the absence of ultrasound, CAT scanning, the blood tests that we've now got 35 years later, he presented acutely at the end of his life. But in fact, he had been in the process of dying for quite some time. And our medical model, which still holds, is that we treat these bits, the little hiccups, and we treat it in an organ-specific way, into the cardiology ward, into the diabetes ward, into the respiratory ward. But this patient is dying. He's been clearly dying, or he or she's from here back. And if we only treat these little bits, we're missing the point. This person is dying, and just like our patient 35 years ago who had a right to know, this person here has a right to know, because we know we are not surprised you'll be dead in the next 12 months. And here's another famous Harvardian, another quote from, this is a Dr. Gawande, some of you have met. People who only die once. They have no experience to draw upon. They need doctors and nurses who are willing to have the hard discussions and say what they've seen, who will help people prepare for what's to come. And that's true, but we also know these are very hard conversations and we're not particularly equipped for doing them. Now, this is some of the research from the ACP Cooperative. And these are surveys of people, not just like us, people in the man in the street. And interestingly, most people have had an internal conversation about how they want to be looked after at the end of their life. They have thought about this. This is not a novel thought. And the sicker they are, the more they've got illness, the more they've thought about it. It is inside there. Secondly, these same people think that the best time to talk about this is before they get very sick. They want the conversations early on. And the third point I want to make is look at that top bar graph. They're waiting for the doctor to raise the topic. Their children and their partner are right up there as well, but they're waiting for somebody else to raise the topic. And unless we do, the topic often doesn't get raised. And this leads us to this whole concept of advanced care planning, which is that as clinicians, it's our job to raise the topic early. And this is advanced care planning. It's a process for discussion and shared planning for future healthcare. It involves the patient, the family, and healthcare professionals. It gives the patient the opportunity to develop and express their preferences for end-of-life care based on their personal views and values, a better understanding of their current and likely future health, and the treatment of the care options available. So it's the whole package. And Atul has already talked about this, so I won't dwell on it. This is the study showing where a group of patients with a life expectancy of 11 months from advanced cancer. And if they were let into the conversation, they started to choose less intensive healthcare. It's very interesting how once patients know what the story is, they start to pick and choose. But they have a much higher quality of life. It approximately halves their rate of depression. And as Atul told us, they live quite a lot longer. So it's our job to change the narrative back here, and as well as treating these acute bits, is to allow the patient to know what the story is, understand the trajectory, and then let them start participating in the decisions they make. And the decisions they make are often counterintuitive to us as healthcare deliverers. But to do it requires quite a package that we don't have yet. It requires society and individuals ready for these conversations. It requires health professionals to be equipped to join the conversations. They need to be trained. These health professionals and the patients need tools to support and capture the conversations, and we need a system to let the right people know what the person wants. It's all very well to have this conversation here, move towns, collapse and be admitted to an emergency ward, and that emergency ward needs to know as well. And so this led us to the development of the Advanced Care Planning Cooperative. And at this point, I want to thank Lee Manson and Shona Muir, both who are here in the audience, and those of you in the cooperative know very well how much work they've done here. ACP is has got a very interesting background in New Zealand. A lot of hospitals were doing it individually, and then when we started doing it in Auckland, we realised we couldn't do it alone. We needed to join up with other groups. And after an ACP conference in Melbourne, a group came back and we had a meeting where 60 people agreed that we'd form a cooperative across New Zealand to further the ACP introduction. And this thing just grew like wildfire. It's been the most astonishing thing I've ever belonged to, and we've got over 1,000 members now, all with the same view that ACP is a good thing to do. And we have it right across. We have ex-Health and Disability Commissioner, we have people from palliative care, we have patients, we have consumers, we've got undertakers, as well as lots and lots of clinicians. And this ACP cooperative is a rather loose association of people with the same idea, but we've got some tight central pieces in it. We've got a tight ethics group, we've got a tight group working on the bits of paper, the forms, we've got a tight group working on training, we've got a tight group working on research, and some of the research I've shown you has come from that as well. Merrin Gott is leading that. And the idea is that Tō Tātou means our voice, and the concept that we use for planning the advanced care planning is this concept of co-design, where we don't do anything without the consumers in the room. So we engage with patients in the community to make the plans. So what have we done? Well, a number of things, and I really recommend that you find your way to this website, Advanced Care Planning New Zealand. And on this is a whole lot of stuff we've stolen from overseas, because it's much better to print with pride, as well as a lot of our own work. And in this website, you'll find avenues to go down if you are a healthcare worker, your patients, if it's your family, or if it's yourself. And people who are self-actuating can actually work their way through all of this and do their own advanced care plans with the help of this website. And on this, we've got educational tools for healthcare practitioners as well. We've got a second program too, which is out in the community, and we've called this Conversations That Count. And this is a co-design process where we have worked with community members, people from Probus, from Rotary, or just interested people, and discussed with them and developed a program for them having the conversations with their peer groups. Because it's very important that ACP is run from the ground up. I mean, not just the cooperative concept I've told you about, but the whole community concept. It needs to come from the people through primary care and eventually up to hospital and hospice. So Conversations Account has been very successful. We've had 2 conversation accounts day, and some of you, or many of you, participated in the most recent one on April 16th. We had Tammy Wells, the Briscoes lady, who left a wig on and talked about some of her recent experiences with family bereavement. And people had the opportunity to send postcards, and we had a huge take-up of this. The community is ready for this conversation, and they are participating. The other thing we've developed is quite a lot of resource, and you've got one of these in your pack, and I'm almost a bit embarrassed about that, because what you've got in the pack is the final ACP plan, and a final ACP plan is not worth the paper it's written on unless you know about the person that created the plan. And so that plan was actually ripped out of one of these workbooks, and the workbook starts off with these questions, which are basically what's important to you. Who are you? What are you like? Where are you from? Have you had experience with death before? Have you had experience with severe illness? How did it make you feel? What do you want? Where do you want to go? And unless you understand that, a do not resuscitation order is almost meaningless. And so we've got all these workbooks, and they're all available on the site for you to download, or you can get hard copies. We're very proud that although the ACP cooperative started as this loose association of individuals, we've had the ability to drive policy. You'll recognise the same logos on the front of the Ministry of Health discussion about advanced care planning, and all 20 district health boards have adopted this whole same process, so it's fairly homogeneous across New Zealand with its own local adaptations. So we've got a system, and we've got a system for the country. We've also developed a really detailed training program. It is hard to have these conversations. And without recognising the irony, we based the tiers of training on the tiers of training for advanced life support systems. So there you go. And so we have level 0, which is everybody learning about it. Level 1, which is healthcare workers who interact with patients. And level 2 is a highly developed 2-day communication course that we developed using trainers from the Christie Hospital in the UK, but now we've trained our own trainers. So we've trained approximately almost 900 people in New Zealand now to have the level 2 conversations. and available through the website. You can get your own level 1 certification, and I encourage you to do that. And we have smaller numbers of the level 3 and then level 4 trainers and train the trainers. So we've got this whole process in place in our training. So that's the end of the introduction to my talk. Because we're asked to talk about what's the future. So what I see for ACP, we've got 3 big things to do. The first is to complete this job. We've only trained 800 people. We think we need more. We need several thousand in New Zealand, people available as go-to people to help with conversations. Not everybody needs level 2 training, but we need to do more training. We need you as leaders in the healthcare world to promote this. If you believe it's a good thing, I'd love you to go to the website. I'd love you to at least do your own ACP. Now, you're all looking pretty healthy. You probably don't need it right now, but you need to know how to experience it so you can communicate with your patients and so you can get your healthcare teams to do the same thing. And I'd love it if you could complete the online level 1 training. You need to do this to help spread the news. Number 1 is we need to keep growing ACP. Number 2, I think we need to take up this conversations account. I'm amazed how powerful this is. A lot of observers have been saying that it's time for a different conversation about healthcare in this country and around the world, that we need to get the community to engage with us about limits of care, about how far we want to go, about is technology taking us too far. But that has to be a social conversation that we can facilitate but don't force on the society, and that's the whole way we do ACP. And the conversations account process, I think we can grow and grow it so that we can have society leading us down this pathway without us pushing them there. And I think number 2 is that we should really encourage the whole conversations account process. The third thing is bigger than ACP, and I don't want ACP to stop, and I think we need to keep focusing it. We know from the international research that if you leave ACP, it withers quite fast. But ACP is based on a simple concept, which is that if you can inform the patient or the person enough, they can start driving their own healthcare. And that absolutely should not be about end of life. That should be about all healthcare, whether you're getting your back operated on or your knee replaced or whatever your care is. And so we have this dream in ACP is that it'll stay, but it'll be like one strand of a rope across the river, and we can help use that to pull other strands across this whole idea of patient-focused, communication-based healthcare, where we can get the patients to be driving the care in a way that makes much more sense to them than for us. And if we could even get halfway to that, we'll have just changed the way that we do things. So on behalf of the cooperative and everybody here in the cooperative, thanks for your attention.